basic scheme of the idea. Okay. As far as I can tell, we wanted to. I mean, you're a right-handed person, so the chance of your language function in being in the right hemisphere is very, very low. It's not impossible, but it's almost zero. Okay. So I do not expect he's going to have any trouble with language as a result of surgery. Okay. I do not believe that you are going to lose any movement, like weakness or paralysis. I don't expect that. Sometimes seizure activity could be in the movement cortex, and sometimes we have to sacrifice those functions when we have to do it anyway. But it's very unlikely in your case. I think it is more of temporal lobe, so movement cortex is away from it. The last thing with temporal lobe surgery is typically a visual field defect. From your eye, the nerve goes all the way to the occipital lobe. Okay, that's how you see things and so on. Now, the small fibers going through temporal lobe, so the anterior portion, if his seizure is really coming from anterior temporal lobe, there's not much to be concerned. But if we have to extend a bit, there's a chance that fiber could be compromised. Okay, and as a result, you could have some blind spot. Okay, because this is the right side, it's going to be on the left side. It's peripheral. So even though it could happen, it doesn't seem to cause major disability for you. It could be a little blind spot on the left side. So those are probably most likely, potential, most possible neurological deficit from the surgery if you're agreeable with surgery and so on. Okay. Now, again, you could ask more specific questions, Dr. Baumgartner, about surgical procedure or complication. It's a brain surgery, so there's always some risk. We think it is less than 1%. The most common thing is infection, because we have to place the electrodes, and you have to go through tooth surgery and so on. And typically, infection is minor infection, meaning that the wound infection occasionally could be inside infection, and that requires prolonged antibiotics, IV treatment.
Now, during the second part of the surgery, is that when they take the VNS out, or would they take the VNS out on another surgery then?
It's up to you. We've done both ways.
Okay.
If you don't believe VNS is doing nothing really helping, then you might as well take it out.
Yeah, exactly.
Intra-op MRI, because he cannot do that.
That's right. That's right.
VNS. So it has to come out.
That might be a reason. Probably we will have to take the VNS out during the first surgery, because we like to get an MRI during the second surgery.
Really, I would like that out, really.
Yeah.
Because my speech.
I hear the way he talks.
Yeah, that's horrible. Yeah, unfortunately. Who placed VNS again?
Dr. Gig.
Okay. All right. Questions so far?
Hospital stay between the first and second surgery, does he stay in the whole time?
Yes. Mm-hmm.
Okay.
So typical schedule-wise, you get first surgery Monday,
Okay.
second surgery on Friday.
Okay.
Okay, or it could be Wednesday, the next Wednesday, like Wednesday, or Monday, Friday.
And then are you still looking at schedules in November, or are you out to December now?
We're up to February now.
Wow, okay.
The beginning of February.
Okay.
I saw some vacancy in November.
Amy told me that you talked to Amy about it. Yeah, she told me February for adult cases.
So we're still, who knows, it could be
Between
between
November
November and
and February.
February, exactly.
You'll get a